I'm Keith Thompson. Jose Garcia and I are co-founders of HealthDigital.ai. We're a health tech startup that has its roots in the Georgia Tech Incubator program. This is Jose and I and his engineering team on the Tech campus working on an early version of our system. I'm an ophthalmologist by training and was on the faculty at Emory as a professor of ophthalmology for 15 years. My career is a little unusual, and then while I was at Emory, I co-founded a tech startup in the laser vision space that was backed by a local venture capital firm, Nora Mosley Partners, and we did well with that venture, having a successful exit for our investors. Subsequently founded HealthDigital.ai with Jose. Jose is a biomedical engineer by training. He's also had significant experience in public health and epidemiology in the renal dialysis space. He's also served senior roles as CTO for venture capital-backed startups with successful exits, and now serves as our CTO. The purpose of Health Digital is to increase access, enhance quality, and reduce cost of outpatient healthcare services that are needed, and deliver them through our platform. I'd like to tell a story of how and why we've brought comprehensive ophthalmology services to MedCura Health patients at your Stone Mountain Clinic with our platform. So to illustrate the problem we're trying to help MedCura Health team address, by telling you about one of your patients we encountered shortly after we set up operations in your clinic, and put a human face on what happens when patients lack access to the medical services that they need. Let's go inside the clinic and meet the patient. Let's go inside the clinic and meet this patient. We'll call him Mr. S. Today, Mr. S is waiting to see his primary care provider in the Stone Mountain Clinic. He's typical of the elderly patients in this clinic. He's 71 years old, of Jamaican heritage, and he has a number of medical problems, including diabetes, which is insulin dependent, somewhat difficult to control, hypertension, heart disease, low back pain. He's had a recent onset of hearing loss, and he wears glasses to drive. Very typical of patients with multiple complex conditions that Dr. Uzzle's team must have addressed. So recently his diabetes has been difficult to control, so he's been seeing the PCP every 3 or 4 months, and after adjusting his meds, his blood pressure is under better control, and that's good news. The bad news is that Mr. S is going blind, and neither Mr. S nor his primary care physician knows that he has a sight-threatening eye disease. Why is he going blind? This patient is male, over 70, Jamaican heritage, and has a number of systemic diseases that are risk factors for glaucoma, a painless progressive sight-eroding eye disease and one of the major causes of preventative blindness in the United States. If we could zoom into his eyes, we'd find that the pressure is too high, and that high pressure damages the optic nerves, over time irreversibly killing nerve tissue and causing a slow, painless loss of vision that occurs over years to decades unless it is diagnosed and the pressure lowered with drops, laser treatment, or surgery. Now, medical care for patients like Mr. S with multiple complex chronic diseases and medical conditions must be coordinated between primary care doctors and medical specialists. So before we partnered with MCH, this is how specialty care in most cases is delivered through off-site medical specialists. Now, his PCP did the right thing. Recognizing he was at risk, he referred him to see an off-site ophthalmologist, in addition to a cardiologist for his heart disease, an endocrinologist to help with managing his diabetes, a pain doctor for his back, and an ENT for hearing loss, and so on. So accessing specialty services through this delivery system is difficult, but it gets worse because many of these specialists don't take Medicaid or have clinics close to public transportation. Many have long waiting lists for patient appointments or are full, and on and on. So does it surprise anyone that of all the diabetic patients referred to ophthalmology for a medical eye exam, only 7% had this completed and documented? Because the eye exam wasn't done, his glaucoma wasn't diagnosed, and that's why he's sitting in the waiting room, unknowingly going blind. So to the extent there's a villain in this story, it's this delivery system. The fact that the whole healthcare system has evolved over many decades has led to this level of fragmentation and friction in obtaining care. So maybe this system is just too broken to fix, and we need to start over with a clean sheet of paper. So we asked the question, instead of requiring the patient to visit multiple off-site specialists, what if we created an access site in the MedCura Health clinic with the right set of technology that would enable primary care patients to consult directly with the specialist they need through the internet? And this would be a comprehensive encounter that qualified for full reimbursement under CMS rules and the Georgia telemedicine statute. To us, that seemed like a much better way to provide access to high-quality specialty medical services needed by primary care patients, and that is what the HealthDigital.ai platform does. So how does the Health Digital platform make ophthalmology available for MedCura Health patients? First, we go inside the clinic and repurpose a few exam rooms that can serve as a Health Digital AI access center. Within these rooms, we place diagnostic instruments needed for a comprehensive ophthalmology exam, including the latest technology that uses artificial intelligence and predictive analytics software to assist ophthalmologists in diagnosing sight-threatening eye diseases such as glaucoma. Within this access center, medical techs and mid-levels perform patient workups with these instruments according to workup protocols and checklists to give the ophthalmologist the information they need. Data and images from these instruments are uploaded into Health Digital's cloud-based software. Without getting overly technical, there are three major components to the software system. There's software known as PACS, or Picture Archiving and Communication System, that is used to organize the information for the ophthalmologist, and there is an interface that allows the doctor to see the Athena EMR. There's artificial intelligence and predictive analytics software that analyzes the diagnostic findings and assists the doctor in diagnosing abnormal findings. Finally, there's a secure telecom system that allows the doctor and patient to visit in real time over the internet. All these features of the exam qualify it for a comprehensive eye exam that is reimbursable on an equivalent basis to an in-person exam. So back to Mr. S. in the clinic. He now has a new low-friction way to see the eye doctor. In fact, he can often see the ophthalmologist on the same day that he sees his PCP on the other side of the clinic. So I want to say a few words to the board about encounter quality concerning Mr. S. If you're a patient like him at high risk for sight-threatening eye disease, then you want to get an eye exam that uses the latest technology that can detect disease and make sure that your doctor has the necessary clinical skills. The good news for patients like Mr. S is that there's a new technology called ocular coherence tomography, or OCT. Think of OCT as ultrasound that uses light instead of sound waves, and it's used to measure the thickness of the retina, which becomes thinned in glaucoma. OCT also employs artificial intelligence, large data sets, and predictive analytics, and it has a 95% sensitivity in detecting glaucoma. Now, some of you may recall from the history that Mr. S wears glasses for distance. You might ask, well, he had to have an eye exam to get those glasses, right? And if he got an eye exam, why wasn't his glaucoma detected? And the answer is yes, he got an eye exam, but because he's price conscious, he had his exam at one of these retail eyeglass clinics that gives you a so-called free eye exam if you buy 2 pairs of glasses. Well, these businesses are optimized to sell inexpensive eyeglasses, and they don't have OCT or other requisite technology to detect disease. So sadly, we found in MCH patients that more than half of them with a sight-threatening disease had previous eye exams in retail clinics that failed to detect the condition. What about encounter cost? If we do an apples-to-apples comparison of costs for an ophthalmology exam that uses disease detection technology, the average cost in a community ophthalmology clinic varies from $125 to $335 and average $250. Our costs at Health Digital range from $45 for self-pay patients on sliding fee up to $250 for private insurer, or $290, and averaged $120. So what's Health Digital's scorecard in bringing ophthalmology on-site to MedCura Health patients? In terms of access, we increased access to eye care for at-risk patients like Mr. S from 7 to 70%. That's a tenfold increase. In terms of quality, off-site clinics detected less than half of patients with sight-threatening disease, whereas at Health Digital we believe we detect nearly all of them That's a twofold increase in quality. In terms of cost, off-site encounters averaged $250, where health digital encounters for ophthalmology encounters were $120. That's decreased the cost by half. So if we define value of eye care delivered to patients as access and quality per unit cost, and we multiply these parameters together, we show that we increase value to MCH patients by 40-fold. So we think this presents a convincing case for adding other specialty services to the platform and make them available to MCH patients. The latest information we have on the number of specialty medical services at the 70,000 primary care encounters generate about 45,000 annual specialty medical referrals, many, if not most of which, we can add to our platform. So if you provide us with expansion capital through a promissory note, we'll be able to enhance our eye care offering as well as begin to add other specialty medical services. And the ones that we have targeted for first edition are ENT, cardiology, pain, and dermatology. It turns out that now is a really good time to expand our partnership. In addition to improving the quality of care for MCH patients, this program can provide MCH with a new source of revenue from origination site fees. Let me explain how that works. During COVID public health emergency, CMS relaxed the rules on telemedicine reimbursement. When the dust settles, it's nearly certain that reimbursement rules for federally qualified health centers will be made permanent. Going forward, there's going to be two separate fees for remote or telemedicine visits. The first is called the origination site fee. For Medicare, it's about $25, and for Medicaid, about $20. The origination site fee would be billed under the Q3014 code by MCH. We have proposed to Jeff that you provide us the space. We provide the technology and staff for all specialty medical visits that we originate from this site, and we'll split the origination site fee with you on a 50-50 basis. The second fee is called the remote site fee. This fee is in most cases the same as that allowed for an in-person visit, so-called parity. Insurers must reimburse treating providers for the diagnosis, consultation, or treatment of the insured on the same basis as a face-to-face visit. Health Digital will collect, or our partner specialty practices will collect, and we'll split this fee on a negotiated basis. There's also an important state law operative known as the Georgia Telemedicine Statute that makes all this possible, but in order to do so, the quality of the exam must be equivalent or better to that of an in-person exam. So that's where our platform comes in. We ensure that we have the necessary technology for the specialist to examine the patient in a manner that is equal to or superior than an in-person encounter. So Jeff asked that I address several issues that were of question or concern to the board. First, what about the longevity of this relationship, and are we just going to take the expansion capital you provide and run off somewhere? I think that's unlikely. First, we've been partners for 4 years, almost going on 4 years, and I've just reported to you the results of that partnership in terms of bringing access to ophthalmology to MCH. But the big picture here is our vision is that we want this to be such a compelling service to federally qualified health centers like MCH that Health Digital platform on site becomes a standard of care for MCH, at least in Georgia, where the rules are very favorable for delivering this service. Now, there's about 35 operators with 150 clinics in our state that care for about 600,000 patients. So we think this is a great opportunity for us to expand this platform to other FQHCs in the state, and we view MCH as our launch customer. So if you're on the board at MCH and you get a call from your counterpart at some FQHC in Waycross, we want you to give us a great reference that we've done great things for your patients. So I think our interests are aligned both in the short term and the long term, and we're looking forward to extending and expanding what we view as a very successful partnership. So questions concerning the promissory note that we're going to use for expanding services here. I told Jeff and Clayton we can make this a simple promissory note because there were some early concerns about your 501c4 or C3, whatever your nonprofit status is. It makes no difference to us. If you think our business has long-term upside, that this note could convert into equity at the point where we go seek external institutional capital, then you would have some upside in that. It's entirely up to the board on how you want that structured. Either way works for us. There was a question about security on the diagnostic equipment. We typically lease the equipment because it's quite expensive, and if we lease it, obviously the security interest is retained by the leasing company. So it's not. I don't think that's feasible with what we have budgeted for equipment. However, we could structure a security interest in our half of the origination site fee, which if we do the 5 targeted specialty services we have proposed, and that adds up to about 20,000 encounters per year, at $20 of revenue for each encounter, that represents a total value of about $400,000 per year to be split between us. So that would be this could be structured as a $200,000 per year security interest. So I think that's certainly doable. Also point out that all funds are going to be used to expand specialty medical services here at MedCura Health on the 5 services that we've referenced. And then finally, just a note about, are we legitimate? Well, I guess 2 things. One, we have a 4-year record as partners with you guys. And second, I would encourage Jeff to give Alan Mosley over at Nora Mosley Partners a call. He knows Jose and I very well, has invested in us before, done well. I think they can speak to our integrity. There were some questions about the software development task, implementation schedule, and software licenses, and Jose is going to address that for you now. So here's the status of our lining up our specialty partners. Obviously, ophthalmology is already covered. I'm simply going to add ophthalmologist under my EIN, which we're already set up and billing for. We have an ENT practice out of Northside. Advanced ENT is ready to go. Alliance Pain and Spine is ready to go on that. We're in discussions with both cardiology and dermatology. They're ready to move forward. Their questions to us are, well, has MCH signed off on this expansion yet? And we say, no, we're still ironing out the final details. But let me just say this. I think there's not going to be an issue getting specialty practices to provide services through this platform. Everyone realizes this is the future. And we're very fortunate to be in Georgia where reimbursement is full. These specialty practices in overserved and competitive areas are looking for a new source of patients, and the forward-thinking ones are very excited about this kind of opportunity. And they're all willing to work under the sliding fee scale as we have with ophthalmology. So, quick summary. We have a proven telemedicine platform that delivers specialty medical services to your patients. I think it's certain that expanding the number of these specialty services will increase the quality of care for your patients. And I think it will also enhance MedCura Health's value as a patient-centric medical home by integrating the delivery of primary and specialty services. We now have the opportunity post-COVID to monetize those visits for you via origination site fees, and word-of-mouth referrals from these ophthalmology practice patients are attracting other patients to MCH primary care. Every week we get a handful. We generate a handful of new patients for MCH just by virtue of people, friends and family members needing a primary care medical home, and we connect them right into the primary care front desk. And finally, I think it gives you an opportunity to partner with us as we bring this platform to schools, nursing homes, and other access sites. And I've told Jeff and Dr. Uzzle about the opportunity we have in Milledgeville, where the Baldwin County school system wants us to put this platform in their existing school clinic. And then by doing deployments like this, it gives MedCura Health an option to grow in that fashion as well.